Anthony DeMaria returns, this time with Dr. Christopher DeFillippi and Dr. Steve Selinger, both associate professors of medicine at the University of Maryland in Baltimore, to discuss physical activity changes in biomarkers of myocardial stress and injury and subsequent heart failure risk in older adults.
So, Chris, perhaps you could begin by giving us the background of this study you've got in press and Jack.
Certainly. Thank you, Dr. DeMaria, and thanks for inviting us to be able to speak. So the title of our publication is Physical Activity, Change in Biomarkers of Myocardial Stress and Injury and Subsequent Heart Failure Risk in Older Adults. And the background to this article is that we and others have recognized that high baseline levels of markers of cardiac injury, the cardiac troponins, I or T, measured by these new highly sensitive assays, or the natritic peptides measured by N-terminal pro-BNP or the BNP assays, are associated in primary community-based populations with an increased risk of developing heart failure or dying of cardiovascular causes. Some research that we've done over the past several years that's been published in JACC or in JAMA has shown that, in fact, many of these individuals don't have static levels over time, and that the trajectory of change is reflected in the terms of the troponin level by a rise of 50% or in the natritic peptide level by a rise of 25% is associated with nearly a twofold increased risk of developing heart failure or dying of cardiovascular causes compared to individuals over 2 to 3 years who don't have the same level of change. And that led us to hypothesize that there would be factors that could mitigate or would be associated with this trajectory of change. Even though these individuals had had decades of prior traditional cardiovascular risk factor exposure, such as diabetes and hypertension, it may be possible to intervene on these individuals through simple lifestyle measures, and this could be reflected by a change in the trajectory of biomarkers. To test this hypothesis, we looked at a long-standing NIH cohort of older adults called the Cardiovascular Health Study. This is a 4 community-based study that was originated in the late 80s and early 1990s. We were able to measure both a highly sensitive cardiac troponin T and the N-terminal pro-BNP assay from baseline blood samples and then samples drawn 2 to 3 years later, subsequent follow-up. And we looked for both what the baseline levels were and then the change in levels.
As I understand it, what you really were hypothesizing is that since the biomarkers of either cardiac injury or neurohormonal activity were predictive of heart failure if they increased over time in elderly individuals, that if you could prevent that increase in biomarkers by some intervention, you would likely prevent the onset of heart failure, and the intervention that you were going to evaluate was exercise.
That's right. Because it was an observational study, we could only look at associations, but this study had very well characterized patients' lifestyle habits and so forth, and they had characterized both the amount of leisure time activity at several time points through a self-administered scale, and they had also patients quantify their walking pace. So we looked at these 2 measures, which had previously published as a composite in other publications from the Cardiovascular Health Study, and we developed a scale dividing the level of leisure activity into 4 different categories from the lowest to the highest, and then dividing walking pace from the slowest to the fastest, the slowest being less than 2 miles per hour, and, for example, the fastest being 3 miles per hour. And we developed or utilized a scale of 1 through 7, or 2 through 7, 2 being the most sedentary individuals and 7 being the most active individuals.
So, Steve, I guess this is a limitation of the study, isn't it, that you're using self-reported physical activity rather than precisely measured, or in fact, I guess the best would be if you had the opportunity to do supervised training.
Yeah, so the gold standard would, of course, be an intervention where you're directly training and increasing physical activity and exercise. And the gold standard for measurement of physical activity would be direct measurement, like an accelerometry-based measurement over a period of a week or so. But in large epidemiologic cohorts, such as the Cardiovascular Health Study, for the most part, those kinds of direct measures are not usually feasible within thousands of people. And the questionnaires that were used in this study are, particularly the Minnesota Life Questionnaire, has been widely used in many cohort studies and is actually found to be predictive of a number of important outcomes in older adults, including in the cardiovascular health study. So there are limitations, but I think also we have reasonable confidence in the validity of the questionnaires overall.
Let's get to the bottom line. What did you find? Was there a lesser increase in the biomarkers in the exercising highly active patients?
Yes, actually there was really quite a remarkable inverse association. So with natritic peptides, the N-terminal proBNP, from the most sedentary to the most active individuals, there was only half the frequency of rise, in other words, an odd ratio of 0.5. And from the most sedentary to the most active individuals with respect to the highly sensitive cardiac troponin T, there was only odds ratio of 0.3, or a little less than a third the likelihood of a rise in the troponin level from the most sedentary to the most active.
So, of course, the biomarkers are only surrogates. Do you have any data as to whether or not the more active individuals had a lesser incidence of heart failure?
Yes, we do. And so we wanted to confirm what other large epidemiologic studies had already shown, in that the more active the individuals, the less likely they were. These were all individuals who had no prior history of heart failure, I should add. The less likely they were to develop their first onset of heart failure. And really, importantly, within each group of physical activity, the presence of an elevation of either biomarker, the N-terminal proBNP or the troponin T, was greatly associated with a much greater risk of ultimately developing heart failure, irrespective then of the exercise level.
Why should some individuals at an equivalent level of exertion have an increase in biomarkers and others a decrease?
All we can do is hypothesize is that, first of all, these are self-reported measures of physical activity and walking pace, and individuals may respond differently to different levels of physical activity. So the biomarkers may reflect both adherence to a protocol of exercise or self-reported exercise, and they may also be telling of the physiologic response to physical activity.
So I guess one consideration that comes to mind is that this was an observational study. It wasn't prospectively designed and controlled. And so what kind of evidence can we bring to bear in terms of the robustness of the findings?
That's an excellent point. Because it is observational, what is very difficult to know is whether the people who were more physically active, was that a conscious lifestyle choice on their part, or were there other health issues or even socio-demographic issues that were limiting their extent of physical activity that they could take part in, and that were also independently making them at greater risk for the development of heart failure? Of course, you can only prove this conclusively with a randomized trial, but in the absence of that data, we performed a number of sensitivity analyses. And particularly, we looked at subgroups that were really free of any major comorbidity, including obesity and chronic lung disease and other chronic conditions that could plausibly limit how active they were. Now, as you can imagine, in a group of people in their 70s, that's a minority of the sample. But even in this most healthy group, those who were more active were consistently less likely to have worsening trajectories of their cardiac biomarkers, in a similar manner that we saw with the whole cohort. And then secondly, in this group of subjects, one of the strongest predictors of mortality in the short term is their self-reported health. And so every year they were asked as how they rated their general health. And we selected those who reported their general health as at least good, or good, very good, or excellent. And in this group that seemed to feel well, or at least tell the study staff that they felt well, we also found the same significant trends: higher activity with lower risk of worsening cardiac troponin T and NT-proBNP. So this consistency of findings, after excluding the patients who would be expected to be most limited in the kinds of activities that they could participate in physically, provides, I think, some consistency and a suggestion that the findings are robust. And perhaps the problem of confounding by their health status is perhaps not as great.
That's an excellent point, because it's an obvious question that comes to mind. It may be that the people who are most active were the healthiest ones to begin with, and your data would suggest that would not explain all of the findings.
That's correct. Within the limitations of this observational design, yes.
Well, as somebody who agonizingly gets up every morning at 5:30 to exercise, I find these data very reassuring. It's worth the effort. I assume that's the message that you would carry forth. A high level of activity, I guess we can't say exercise training, but a high level of physical activity seems to be somewhat protective against the ultimate development of heart failure, at least in elderly individuals or older individuals. Does that sound right?
Yes, very much so. And I think we can hypothesize based on this information that years before the development of symptoms, there are biochemical changes that are taking place that can be mitigated through physical activity.
Very nice. As I say, when I get up tomorrow, I will feel so much better knowing these data as I pedal along my bicycle. Thanks very much for sharing these data with us.
Thank you.
Thank you.